All right, hello everybody. Thank you for coming. And we're going to get started. Today we're talking about inputs for cardiac outputs. And I'd also like to welcome to our sessions the Anesthesia Critical Care Fellows and the Heart Center ICU APPs, and everyone should please feel comfortable speaking up and asking questions at any time. This talk is kind of a 2.0 or a 201 to our LV function talk. Which I guess would be LV function 101, and this would be 201. And so here we are in our curriculum plan in progress. We talked about LV function and RV function at the basic level, and now, or intermediate level, and now we're talking about getting cardiac output by echo, why you want to do it, and how to do it. And soon, in the near future, in between some of these lectures, we're going to be having some just straight echo drills where we'll be pulling up some echoes that were done in the ICUs and having group discussions discussing how to read and interpret them. So the goal for today is to learn how POCUS can quantify cardiac output and why you want to. Unlike previous sessions that were completely ignoring acquisition, some of this will also include important points for appropriate image acquisition. So that's it. All right, so why do we care about quantifying cardiac output on a bedside echo? So hopefully I will convince you. I mean, first it's cardiac output. I think we all just know that cardiac output is important. But I'm going to also try to illustrate for you several specific applications for where cardiac output can help you make a diagnosis that maybe with the previous echo skills that we talked about doing in the first LV function lecture could not. So for example, take a look at this echo here. And what would you predict the EF is, Chris?
The EF?
Yeah, you can make something up.
15%.
15%. Okay, I made up 10%, but agree, really bad. And what's the EF here? Anyone? Laura? Normal. Okay, so 60%, right? So if you have a patient who's in shock, you might look at this EF of 10% and say, maybe that's the cause. But I could tell you that these patients, believe it or not, have the same exact stroke volume, because this patient here has an EF of 10% with dilated cardiomyopathy, but is compensated and is chronic. And at the bedside, your LV function, your assessment of EF, or obviously we don't do EF, but all the other measures that we do, you would have also told me that the LV systolic function was extremely poor on the clip on the left. But if you did a cardiac output, you can actually tell that this stroke volume is actually normal and maybe is not the cause of your shock. Maybe even if you don't have a previous echo on this patient, but you know that they're ill and you don't have any records and you see that their stroke volume is normal, you might think that maybe this is not the most important point.
Is that haziness or stasis?
This haziness here, it could be. I would be careful about that. I think it could just be a little bit overgained as well, but could definitely be, because you would expect that with such low. Chris was asking if this echogenicity here is stasis, and it could be. We would have to just be careful. All right, so that's one application. Here's another, right? You might remember this clip from one of our first talks. This is a patient who's hyperdynamic. So is this patient, and you might see that they're hyperdynamic. The ventricles don't seem to fill very much, and they're almost like an EF of almost 100% as far as you can tell. So you might think that this patient is hypovolemic, or maybe they have a high output with very low SVR, and so they're hyperdynamic for that reason. Maybe they're septic or cirrhotic. So another situation where just looking at your gross assessment of LV function maybe would not help you, or at least would still leave you with some diagnostic questions. But if you did a cardiac output and saw that it was very low, probably hypovolemic. If you did a cardiac output and it was very high, probably not hypovolemic. There's another case. This patient's in shock. Anyone happen to know why? So prelude to another talk, but you might actually notice that this patient also has, let's say, a normal EF. But if you forgot to put color on, you might not notice that this mitral valve leaflet over here is actually prolapsing. Right? So obviously this isn't, I'm not suggesting that you use cardiac output to diagnose MR, but if you did cardiac output, you might see what looks like a normal EF, but it could all be going backwards. And your forward cardiac output could be extremely low. So in a patient with severe MR, using cardiac output will also give you a sense of what their forward flow is when EF can't really tell you. Do I have another case for you, or is that, there you go. Well, here's the last one, or just another one, which is, here you're going to get used to seeing this screen, because this is going to be the clincher to our cardiac output assessment. You might notice that this patient has extremely poor windows, might be very difficult to assess LV function, but you can actually, as you'll know by the end of today, with this, you'll actually be able to get a very good sense of cardiac output. So again, cardiac output can help you diagnose or assess LV function in a situation where you have very poor LV windows. So some specific applications, like I'm mentioning, hyperdynamic function, MR, you can inform the acuity and compensation of reduced EF, poor windows. We're also going to talk about the use of cardiac output measurement when we have our fluid responsiveness lecture. So technically, this is still an advanced skill. It's not going to be for long, but it does require a proficiency with basic image acquisition. So if you're not there yet, this is going to be a future skill. But the point of this is really to understand the concepts behind cardiac output measurement. For those of you already at a proficient level of basic image acquisition, this will also help you start working on getting your advanced cardiac output measurements done correctly. And finally, it's actually tested on the pulmonary and critical care boards, not just the echo boards, but you'll see questions regarding LVOT VTI and cardiac output on the pulmonary and critical care board. So another reason to understand these concepts. So what we're going to do today is I'm going to introduce the overall approach, introduce the detailed approach, and also incorporate some common pitfalls. And so the overall approach to assessing cardiac output is based on this equation here, which we're all familiar with. Cardiac output is equal to stroke volume and heart rate. And if we have time one day, I can show you how you can use an echo to calculate heart rate, but it's actually not the best way to do it. We have better ways to know the heart rate. And so most of what we're focusing on for the echo is stroke volume, right? The echo is going to tell us the stroke volume, and then you plug in the heart rate and you get cardiac output. So how does echo tell you about stroke volume? So take a look at this. Lots of feelings right now: nostalgia, the smell of Play-Doh, disgust. But if I asked you to calculate the volume of this Play-Doh pile here coming out of this Play-Doh noodle maker, could be pretty difficult, right? But another way you could do this is by focusing, and let's pretend that this was not a star but a circle. I couldn't find a GIF with the circle noodle maker, but let's pretend this was a circle. Another way to sort of measure this volume would be if I told you to focus right here at this circle where this noodle is coming out of the Play-Doh maker, right? And if you just focused on that and ignored everything that happens after and everything that happens before, if you just sort of took a video of this snapshot right here and let the noodle come out, it would make a cylinder. Right now, it's not, it's piling on the floor and it's making a whole mess. But if you were just focusing on it as it's coming out here and just watching that spot and plotting that over time, you would have a cylinder, right? And the area or the volume of a cylinder is actually extremely easy to calculate, right? It's pi r squared for the circle times the height. And so this is what you rely on to measure cardiac output on an echo. So where in the cardiac cycle does blood assume a circular shape? That would be the LVOT, and we're going to show you that shortly, right? And so the question is, or to relook at this, if you imagine that this was the LV and it's full of blood in whatever shape your LV is, and then as it's contracting, it's pushing blood through this LVOT. So the blood that's in this big bag of the LV is now being forced through a very circular orifice as it's traveling through the LVOT into the aorta, which is over here, right? So if you try to calculate the volume of the blood in the aorta, it's going to be difficult. The aorta has a shape that varies over time. The LV also has just its own unusual shape. But if you somehow just focus on that LVOT and can watch it come out as a cylinder, then you would have a simple time calculating the cardiac output. So in which views on the echo and the basic views that we're used to seeing, in which views do you actually see the LVOT? The answer is in two views. You see it in the parasternal long axis, as we're now familiar with, right here. And you also see the LVOT in the apical 5-chamber view, right? This clip here is nice because it starts in an apical 4. You have the left atrium, left ventricle, right ventricle. And then as you fan upwards, you open up the LVOT, and you have that 5th chamber, which is the aorta, right? And so here you're seeing an LVOT, and here you're seeing the LVOT. And these are the images, these are the clips that you're going to need to dig into, basically, to calculate your cardiac output, right? And so this area here is I made a very, very thin cylinder here, but this is the area where you're going to be, where your blood is assuming that circular shape, right here and right here, so to speak, right? As blood is traveling, now out here, it's already not a cylinder. I should have made this shorter, right? But as it goes through that ring of the LVOT, right before it goes through the aorta, the blood is assuming a circular shape. Okay, so using the parasternal long axis view, you're going to be getting the diameter of the LVOT. And from that, you can calculate the radius, of course, right? And what we're going to focus on is, again, this is the overall approach. We're going to dig into these. But when you're using the apical 5-chamber view, that's where you're going to be getting the height of the cylinder. And that's where Doppler physics is going to come in. And I'm sorry about that. So that is our overall approach. You have cardiac output, which is stroke volume times heart rate. And the stroke volume is using this cylinder model where the radius, the surface area here is, you're getting from the LVOT, you're getting from the parasternal long axis view to get the radius. And then you're going to be using the apical 5-chamber view to get the height. And based on that, you're going to calculate a stroke volume, multiply by heart rate, and you've got yourself cardiac output. Any thoughts or questions so far?
You'll probably come to this, but in case you don't, one thing that they told us in the echo course was, this can get you cardiac output, but some of the measurements you make are sort of all that matter to you. And so if not now, it's something you just comment on, like, why do these things that might introduce error if you can just measure the VTI?
Oh, okay, so why, so Chris is asking why, I think what you're asking is why do we have to measure LVOT? Why, a lot of people just look at VTI and don't really get the LVOT diameter, and why does that, why would they do that? And I will address that. And if I don't by the end, let me know. But great question. So the detailed approach for getting cardiac output is now getting the LVOT diameter from the parasternal long axis, which I'll show you, and I'll show you some pitfalls. Brief overview of Doppler physics, because that's going to be needed to understand how you're getting this, or how you're getting the height of that cylinder from the apical 5-chamber view. And throughout, we'll be incorporating some pitfalls. So how do you get the LVOT diameter from the parasternal long axis? So this is your normal, this is a normal parasternal long axis view. It's the same clip from all of our lectures, so I'm sure it's becoming familiar to you. How can we optimize this image to focus on the LVOT diameter? Now, usually, you're getting this parasternal long axis because you want to see the LA, and you want to see the LV, and you want to see the LVOT, and you want to see the RV, and you want to see this width. But if you just wanted to focus here and get this measurement right here, this LVOT diameter, there are some things we can do to optimize this clip. So if you're in your parasternal long axis, the first thing you could do is center the LVOT. Right here, it's on the side. You can move it to the center because your resolution on an echo is always going to be better on that straight axial plane. So that's one thing you can first try to do. Step 2, reduce the depth, right? The more depth you have, the less resolution you're going to have for the entire image. That's physics that we're not going to be discussing today. But you don't need to see the left atrium, right? So if you reduce the depth of your echo, you'll be able to see more of the LVOT and get a more accurate measurement. The other thing you could do is you could reduce your sector width. Notice this is a pretty wide wedge, and that's intentional, but you can actually adjust that and bring that wedge inward. So you're decreasing your depth, decreasing your sector width, centering your LVOT, and finally, you could zoom on the echo. That doesn't really increase your resolution, but it might help you improve your measurements. The truth is that sometimes I find zooming and sometimes even reducing depth too much, sometimes it just gets actually too grainy, and you actually do need to undo some of these tricks. But these are all the tricks you have to, at best, try to maximize the resolution of your LVOT diameter. And when you do all these, your echo might look something like this, right? Center, narrowed sector width, no resolution, no depth here, right? Reduced depth. And you see the RVOT is gone because we've zoomed. Otherwise, you're reducing your depth wouldn't eliminate the RVOT. So this is also zoomed, right? And now you're having a really nice view of this aortic valve leaflets opening and closing. Now, where do you want to measure it? You want to measure at mid-systole when the leaflets are maximally open at the insertion points. And this is crucial, that you choose one spot to measure, and this by convention is what we've all chosen. This is what's most likely to be a circle. This is also just what you choose by convention. This area right here, that's where you're going to be measuring your LVOT diameter, right here. In this case, I'll tell you 1.86 centimeters, right? Which gives you a radius of 0.93 centimeters. This is crucial because now we're going to be going to the apical 5-chamber view in order to measure the height. And that, based on all the physics that we're going to talk about, really depends on you knowing and placing your marker exactly in the spot where you measured this in the parasternal long axis view. So basically, you have to identify this exact spot in the apical 5-chamber view as well as this parasternal long axis view. But if you do that, then you'll be able to get an accurate measurement of cardiac output. So some key image acquisition points, just to review. The error, one important point, it's not a review that I didn't mention yet, is that errors here are squared. This is starting to get at what Chris was alluding to, where there's some issues where one small issue with your measurement can have dramatic impact. The area of that cylinder is going to be pi r squared, right? And we're getting that radius from here. So if you make a mistake, you are squaring that mistake, right? So you're going to have a dramatic error when you get that pi r squared. The height, again, of the cylinder, you're going to be getting from the apical 5-chamber view, but that area, that circle, that's coming from here, and that pi r squared, your error is going to be squared. So you have to be accurate. Again, optimize your depth, your gain, your sector width, your zoom, measure at the leaflet insertion sites at peak or mid-systole. And this also gets to some of Chris's point, which is their LVOT diameter will not change within your patient throughout their hospital course, right? So if you want to know their cardiac output, and you're going to have to multiply their pi r squared, which again, you should know in advance, actually the echo will do this for you, but you're going to have to measure their LVOT diameter, and you're also going to have to get their VTI from the apical 5-chamber, which we'll talk about. If you're doing a serial assessment on the patient day to day, or you want to see the response to a fluid bolus or what their cardiac output is today compared to yesterday, you don't have to remeasure your LVOT diameter. That's not going to change. It's just pretty fixed in a patient over one hospital stay. So once you have this one time, you don't necessarily need it again. A fun, unreliable fact, and I guess this will finish up my comments to Chris's point, is that most patients, you should not rely on this, right? Most patients have an LVOT diameter of 2 centimeters, maybe 1.8 to 2.2, right? And the radius is therefore 1, which means that your area of pi r squared is really often going to be pi. And some people will sometimes, especially if you can't get a good parasternal long axis view, will hedge on this and say, well, then we could really just look at VTIs. A normal VTI will be somewhere between 18 and 22 centimeters. And if we can't get this LVOT diameter, well, we'll just go based on VTI. But you can be really fooled, especially in people who are, for whatever reason, have a smaller LVOT diameter or a much larger LVOT diameter, then their VTI will not apply. Well, you can't really assume that their VTIs are normal. And then you're making all these wrong assessments based on that assumption. So it's something to be very, very cautious about, but sometimes people do. Best thing to do is obviously get your LVOT diameter once, then use your VTI throughout the hospital course. If you can't, be very, very cautious in using the VTI. What you can do with the VTI is still trend that over time. But to assess your actual quantity of cardiac output day to day, you can't, or at least your initial cardiac output. So if you want to see a % change in cardiac output, you'll still be able to use your VTI without parasternal long axis views.
Jonah, could I ask a quick question?
Yeah, sure.
Would you ever look at an old echo to see like an LVOT diameter to correlate if you're unsure, if you feel like you had a good measurement, or if they had a recent echo, is that reported? That's something you could just use from the echo?
It's a great question. Unfortunately, on our echo reports, LVOT diameter is not generally measured. It's one of those POCUS critical care echo things that we don't do. In fact, VTI is also not measured usually. And then you wouldn't really be able, you could try, because there are markings on the side of the, it's a good point, right? There are markings on the side of the sectors, right? Where you can sort of see how many centimeters something is, but you're going to be doing a lot of guesstimation unless you have like calipers. And then you can lead yourself astray, but it's a good thought. I guess it's something you could certainly look at and try to get a sense of if you think that they're around the 2 centimeter mark, but can't fully advise using that if you're going to be making fine assessments. Great thought, great question. Okay, so getting the surface area of that, or not the surface area, but the area of the circle part of your cylinder, a little pretty straightforward, I think, from the parasternal long axis view. But how do you get the height of that cylinder? Now, remember that the blood is not flowing through and creating an actual cylinder. It's just creating a cylinder as it's going through the LVOT. So we have to sort of create that video I described where you're just looking at that LVOT and you're watching blood as it's going through that and sort of figuring out how much distance it's passed through the LVOT, but we don't really have such a camera, right? And that's where we're going to be relying on some Doppler physics. So we have the LVOT diameter, we need the height or the distance of the cylinder, but it's not really creating the cylinder, right? It's just as it's passing through this LVOT, it creates the circle. And if I could find out how much blood has passed through that LVOT, I'll know the diameter, I'll know the height of this potential cylinder. So cannot be measured directly. So instead, what Doppler will do is, and you don't really have to know calculus, but knowing of calculus is nice. What we'll do is you'll choose the spot on your apical 5-chamber view. you point to the spot, and the spot you're trying to point to is exactly the spot that you measured in the parasternal long axis view. And using Doppler, the machine will measure the speed of blood as it passes through that spot in the LVOT, which changes throughout systole, right? It speeds up and then it slows down. So it's measuring all the speed as it speeds up, as it slows down. It's measuring the speed of blood as it passes through the LVOT, right? And it plots it over time. And if you take the integral of that speed, and you don't have to do calculus because the machine does this for you, but the integral of speed is distance. And in that way, if you get the speed of the stroke volume through the LVOT, the machine will do this calculus for you, give you the distances traveled, and then you're done, right? And this is called the famous VTI that you've probably heard of, right? Hopefully now it makes at least intuitive sense. It's velocity time integral. You're getting the integral of the velocity through the LVOT over time. And what that will tell you is how much distance that blood has traveled. And you know that as the blood is traveling through that spot, it has the same surface area of that, or area of that circle that you got based on the parasternal long axis view. And using that, you're going to be able to calculate your stroke volume. And good news, if you use the machine correctly, the machine will do it for you. Okay, so how does Doppler do this for us? So basic ultrasound physics here, you have a sender probe, and it sends out waves at a certain frequency. And as it hits a stationary object, if it hits it head on, the waves will be transmitted back to the ultrasound probe at the same exact frequency. Note, by the way, that frequency is not the same thing as speed, right? Frequency is just how many times it makes you get a wavelength in a second. So the speed that the echo is reading is basically, we know that the speed of sound through soft tissue is 1540 meters per second, which you don't need to know because it's in the echo machine. But knowing the speed with which the machine has sent out an echo, it can then calculate the distance when it comes back. And so that's how basic echo works. Sends out an echo, hits an object, it comes back at the same frequency. And so it knows, based on the speed of sound in soft tissue, exactly how far that image is, and it creates this little echogenicity for you to represent that there was something there, right? Now, what happens if that object here was not stationary? What happens if this object was moving? So then something interesting happens, which is that, so this is a blood cell that is moving towards the probe. So the probe sends out a wave at this frequency, whatever it is. Now, the moment that it hits this blood cell, the blood cell is rushing towards the probe. So I kind of think of it as squishing the frequency, right? And the frequency that comes back is going to be different, higher than the frequency of the wave that was sent through initially, that was sent by the probe. Now, the speed that this travels through the soft tissue is still the same. So it's going to be represented on your echo as being at the same point. But the machine is able to detect this change in frequency, which I'll show you, and know that the blood cell must be moving towards the echo probe. Not only that, it can calculate the exact speed at which this blood cell is moving towards the echo probe at the moment that the ultrasound hit that red blood cell. Okay, same thing if the blood cell was moving away. Sends a frequency of a certain wave. As it's hitting the red blood cell is moving away. I kind of think of it as sort of like hanging on for a second before the blood cell, travels away, and then it comes back at a slower frequency. And so again, the machine will know that this red blood cell was exactly at this spot based on the speed with which based on the time with which it took that sound wave to come back, but it also notices this change in frequency and says, hey, this frequency is lower than the frequency that I sent, and it's lower by this amount. And using special math, it's able to calculate exactly the speed with which it's flowing away. Any thoughts or questions so far? Okay.
Why do they choose erythrocyte here? Is it actually erythrocyte? I would always think about it as like a bolus fluid. I feel like it doesn't actually apply to the size of the cell.
I have the same question. Chris is asking if it's actually at the cellular level or just the bolus of blood, and everyone writes about it at the cellular level, and I kind of agree. I don't know. I'm not a physicist, but I suspect that, right, it's the bolus. It doesn't, I guess, make much of a difference, but I always wonder that too. But everyone talks about it as the red blood cells sort of as a whole, so maybe there's probably some truth to that. But good question. Okay, So the last thing you need to know about this is that what really makes a difference, as you can imagine, is the angle at which you're catching these speeds. Now, these pictures make it seem like the ultrasound is hitting the red blood cell head on, and the red blood cell is heading head on towards or head on or back on away from the probe, right? But very often we're not lined up perfectly. And what happens is you're getting it at a bit of an angle. You're in that apical 4-chamber view, and your head is, and you're trying to angle and try to match up with the direction and the orientation of the heart. But very often you'll be off angle. And so the red blood cells are passing this way. And so they're still having net vector towards or away from the probe, but the difference in the frequency is not going to be truly representing the speed of the red blood cell, right? Because there's this angle that you have to account for. And you can calculate, so if you knew, but the problem is you won't, if you knew the angle, you can account for that, right? Then you could just tell the probe, well, okay, account for this difference in angle and know that, okay, I calculated speed of X, but I know that this is the angle, so you could do some fancy math, and I'll show you the equation in a second and say that, okay, now we know how to adjust for the actual speed, but you don't know that angle, right? This is why the best way to know that you're on the right angle is to be on the right axis. As the more on axis you are, the more likely you are going to be oriented towards that angle, towards the direct direction of the flow of blood, right? Now, if your angle here is 0, so the cosine of 0 is 1, right? That would be, and this is cosine of that angle is going to be the adjustment in the equation that I'm about to show you, right? Now, if you're off by 20 degrees, so the cosine of 20 is 0.94, which means you'll be off by around 6%. And so being off by an angle approximately of around up to 20 is sort of generally accepted as still okay if you're going to be making cardiac output assessments and judgments. If you're off by 60 degrees, suddenly you've got a 50-50 shot here, right? You're 50% inaccurate, right? And so it's really important to be close to that 20, but again, you can't actually calculate that exact 20. So what you're going to do, and I'm going to show you some tricks for doing this, but I mean, the first thing is to make sure that you're on axis as best as possible. And then the other thing that I'm going to show and recommend is that you use color Doppler to sort of show the maximal flow of blood through the LVOT, which suggests that you're closest to being on axis. There's other corrections you can do, but being on axis is crucial because this is a mistake that you can really throw you off. So the machine is going to recognize the frequency shifts and convert them to a speed and direction. And here it is. So here's your velocity. The machine is going to calculate the velocity of blood. How is it doing that? It knows the speed of that sound travels through soft tissue. That's the 1540 meters per second that I mentioned. He looks at the difference in the frequency change, the frequency now minus the frequency that I sent, over 2 times the frequency that I sent times the cosine of that angle. No need to memorize this at all. If you're taking echo boards, then yes. But for your purposes, just the point of me showing this is to demonstrate the power of this cosine theta. This is really important, right? And this is going to impact your measurement of your velocity. And if you're off, this entire equation is going to be off. There's your 1540. Okay, so how does the machine represent to you this velocity that it's measured? Well, it could do it in a couple of ways. The first way, and perhaps the crudest way, but easiest to maybe understand from a basic level, is color Doppler. And also power Doppler, which I'm not going to talk about, but color Doppler, right? So in color Doppler, the machine is just attributing a color and a density of that color, either red or blue, based on the speed that it's calculating. And this is what's behind the machine when you're seeing color Doppler. It's doing all this fancy calculations in the background and generating for you a picture. If it's red, it's going blue away, red towards Bart. So if the flow is blue, that's any flow going away from the probe, they'll demonstrate to you as blue. If it's going towards the probe, it's going to be red. And it shows it to you as sort of a picture. It's not helpful if you want to pinpoint an exact precise velocity. There is a bar on the side that sort of gives you an idea of the range of velocities that are being captured, which I'll try to point out. I forget if I have a slide on that, but that's what color Doppler is doing for you. But if you want to get really specific, if you really want to pinpoint the velocity, then you need spectral Doppler. And spectral Doppler is the term for all the Dopplers that you can use on your echo that will truly graph the actual velocities for you over time. And there are a few ways of doing this. There's pulse wave Doppler, continuous wave Doppler, and tissue Doppler. And today we're going to talk about pulse wave Doppler. In our next talk, when we start talking about TR and RVSP, which I strategically removed from this talk because I realized it was way too much, we're going to be talking about continuous wave Doppler. But today we're talking about pulse wave Doppler. And the major difference here is,
Before we go on, I have
yeah.
a question with the equation. They told us like if you got multiple VTIs, then you should go with the highest one because it's that's sort of like you can easily underestimate it, but you should take the highest number is probably the true number. That being said, here, if you're off, then your theta would shrink the cosine there, and so you get a smaller denominator and therefore a higher velocity, and would overestimate it. And so it seems to conflict with what they told us before. So this seems like it would inflate your cardiac output if you were off axis.
It would deflate it. You would end up with, I have to think this through now, but if your cosine, if your angle is high, this would be lower, your velocity would be higher, but that might, for calculus reasons, maybe I'm wrong, still make your integral lower.
Oh, I see. So
because you're still doing the VTI, so it's possible your velocity would be higher, I guess, based on this equation. I think that's true. But it must be that I'm not a calculusist, but it must be that your integral will still end up being lower.
Got it, because for the same time, you'd be covering more distance. Okay. All right.
I could be wrong about that. I also have to think about it. It's a good question, but it is true that basically the closer. So Chris is saying that if you're doing it a few times, you should go with your highest VTI, because you could really only be off in the worst direction. Right? You can only be off by underestimating. You can't really be off by overestimating. And that is true with one caveat, which is if the patient has an arrhythmia, then beat to beat, you might have different stroke volumes. And so when you do have such a thing like AFib or another arrhythmia, then you have to just make sure that you're consistent. And the best way to measure your cardiac output is by averaging several VTIs. If you know that you're in normal sinus rhythm and you're getting a VTI that's sort of different with two different hand motions, then you should go with the higher one because that's going to be your more accurate one. I have to think about the calculus and the equation. I could be wrong because still your velocity should be lower regardless. It shouldn't just be the integral. So I have to think about why that is. I also rearranged the equation, so I may have made a mistake. All right. So again, this is basic color Doppler physics. So if blood flow is going towards the probe, then you have red blood flow. The ultrasound is going to capture that your frequency has changed and got increased. So you're going to have red blood flow coming towards. As it makes that 90-degree turn, you actually, if you're perfectly at 90 degrees, then the machine will not recognize any Doppler shift, and it'll be dark. And then as blood is flowing away, it's blue. Obviously, it's important to remember blue and red do not correlate with artery or vein. Depending on how you're orienting the probe, blood flow in the same vessel could be blue, could be red. And this is your basic color Doppler. So this image that I showed you before, right, has a lot going on. You might appreciate there's like a bolus of red that happens here. And that's blood that's coming from the left atrium going into the left ventricle. You might also notice on this end here, you have this like blue that appears. And that's where the LV is contracting and blue blood flow is going away from the LV into the aorta, which we're going to be spending some time looking at in just a moment. Right. And so understanding like when you're trying to get familiar with looking at color, especially on like a fast clip like this, you might want to slow it down and look at it like sort of frame by frame and see exactly where it's going. This patient also has MR, so that really bright blue / sparkling flow backwards, that's again blood flow going backwards in your MR. So you have red blood flow going in, regular filling, and then during systole, you have MR and you also have LV outflow, just getting used to using the different colors to interpret Doppler. So that's color Doppler. So what pulse wave Doppler is, the way pulse wave Doppler works is that it sends a wave to reach a specific point. Again, because it knows the speed that an ultrasound wave propagates through soft tissue, it knows exactly when a wave is going to hit a specific point. So if you pinpoint a point, you can tell the machine, I want you to send waves to that point, and it will listen to only what returns from that point. It will not listen to anything else. So it will send out a burst, it'll wait, it won't listen to anything else that's returning until it hits that certain time, which demonstrates that it's listening to something that hit the point that you chose. And then it will note the Doppler shift. And this will yield the speed of anything moving at that specific point. The difference, I'm not going to talk too much about, I said I wasn't going to talk about continuous wave Doppler, but just to understand for today, continuous wave Doppler does not pinpoint a specific point. It will just look at any waves that are coming back at any speed and it'll plot it all for you. So if you want to know the speed that blood is moving through a specific point, which as you understand now is critical for getting cardiac output, you need to have a pulse wave Doppler, not continuous wave Doppler. Asterisk, we'll come back to that asterisk, but this is the baseline. So if you had a pulse wave Doppler, and you put your channel right at the LVOT, This is what it's going to look like. Then it'll start plotting velocities over time. It's not going to be this perfect triangle, but this is time. The y-axis is velocities. You hit play, it's going to start giving you velocities over time. It speeds up, shoots through the aortic valve, and then sort of slows down as it tapers off. And that's what your pulse wave Doppler is going to be doing. And when you get that VTI, you're going to get the distance, you're going to get the height of your cylinder. So how do you get the VTI from the apical 5-chamber view? Scary, but this is how. First thing is to find the apical 5-chamber view. So that's where you open up and you have the 4-chamber, you fan upwards towards anteriorly, and you open up this aortic valve right here. And you ideally want to line up the LVOT with the center, because it's going to be extremely important to get that blood flow. As you saw from that previous clip with the outflow, blood shoots out the aorta like this. So if you're getting it off to the side, you're already going to mess up some of your angle, right? So you want to line up that LVOT directly with your probe, and also make sure that overall your image is on axis, because otherwise your angle could be off. Note that there's two different angles that we're talking about. There's the angle of insonation. That's the angle at which you're getting this entire image, right? And you could be off. You could be foreshortened. You could be forlongened. I don't know. But you could also, in addition to that angle, the angle of your entire image getting, the plane of the heart, the flow itself could be towards you or away from you or on axis, right? So there's the flow, the angle on the image itself, but also the angle of the entire image that you've taken. There are some corrections you could do, which I'll show you, for the angle of the flow, but you can't correct for just being at the wrong angle to begin with. So you want to line up the LVOT at the center just to optimize being on angle as much as possible. And this is what I was alluding to earlier. Once you're in your apical 5-chamber view, you want to, I've been taught to use color Doppler to identify the area of greatest flow. So you get this nice clean blue outflow. If you were to fan upwards, this might, start to fizzle out. If you were to fan downwards, it might start to fizzle out. Wherever it is that you're getting that cleanest blue jet is some sign, is some clue that you're at least on axis as best as possible. And so you have to just play around a little and make sure that you're there. And then you click your pulse wave Doppler and you place this gated channel here right where you think those leaflets are inserting, where you measured the LVOT diameter in the parasternal long axis view. That's crucial, right? Now you may notice that as best as I tried here, I'm still not quite on the angle of the flow. I think I'm on axis on the apical 5-chamber view, right? But the flow is still sort of just going off screen. And so as a bonus, you can do this little angle correction with your machine, right? But the problem with this is that blood is flowing in 3 dimensions. It also could be angling towards the screen or out of the screen, right? Towards the room, into the computer. And you're only correcting for 1 dimension. So you always want to optimize your angle as much as possible, to rely on the angle correction as little as possible, because the more angle correction you have to do, the more likely you are to not be accurate overall. But that is an option that you can do that's pretty straightforward with the pulse wave Doppler. And then you hit go, and you get this envelope.
So that angle correction is not changing sensing, it's actually just changing it's adjusting the calculation on the back end?
Yes, this angle correction is just adjusting the calculation that the machine is doing in the background using that equation that I showed that hopefully was correct. Now you'll notice, so this is your speeds, right? So this is the range of speeds, and you'll notice that the envelope is kind of narrow, is kind of dark in the middle, because you're getting just one spot. And so blood is traveling through that spot pretty uniformly. It speeds up and it slows down, right? There is nothing at this point in time traveling at this speed, right? Whereas if you were on continuous wave Doppler, you would be getting speeds of anything here. So you usually generally would have a filled in envelope representing all the speeds along the length of this line. But because we're on pulse wave Doppler and we're only getting the speeds of blood as it's moving through here, we get this cleared out envelope with a large, with the outline is white. Those are the speeds that we're seeing, whereas the inside is generally not filled in. This vertical line here is the atrial aortic valve closing, the aortic valve click, and that's normal. You want to see that. And then you have to measure and you trace with the machine. And our machines actually have some AI. They might try to guess, but it's best to do it yourself for now. When you want to, you generally choose the spot where, some of this is just sort of maybe some like turbulent or just flowing around at around that area before systole. Your clue that it started is when it shoots out. So you want to start, you don't start here, Ignore these vertical lines. This was just for the machine to calculate the heart rate. But you don't, when you want to start tracing is where the flow starts to shoot out directly. So you start here and you trace it down here, and you come all the way down here until the aortic valve closes. So this is a correct tracing. And when you do this, you'll notice that the machine will tell you the LVOT VTI. You don't have to whip out a calculator and do the calculus. It will tell you the VTI is 19.5 centimeters. And that is the height of that cylinder. And if you plug in the heart rate to the machine, which is 70, the machine will now tell you stroke volume. It could have given you the stroke volume without the heart rate. And it'll also give you cardiac output of 3.7 liters per minute. And if you, again, put in the LVOT diameter before into the machine the correct way, and you do this the correct way, it will calculate all this for you and tell you your cardiac output and your stroke volume. So,
do you mind going back a slide? Do you mind if I ask a quick question? When you're looking at this pulse wave Doppler diagram, if you're seeing fuzzing out, or kind of like it, like the curve itself is like broader in some points, does that say anything for like the quality of the VTI? Because I guess in theory, if the pulse wave Doppler is directly at one specific point and it was the velocity of that point, it should just be a line. Is there any like concern with it being more fuzzy, or does that question make sense?
Yeah, no, it does, and it's correct. So yeah, the fuzzier it is, the less accurate it probably is. One thing you could do is reduce your gain, and that will sort of filter out some of the lower velocity signals that you're getting. And sometimes it will actually, you'll actually notice, like for example, some of this fuzz might disappear, and that could all just be artifact as well. And your correct tip would be, let's say, here. So it is important to get as sharp borders as possible. If the view you're getting is like filled in or extremely fuzzy, I would not use that for a VTI. You want to get something. This is like borderline already. Even this example that I'm giving you is not like the most perfectly ideal. It's good enough, I think. But you should be worried if it's extremely fuzzy, or if you're not getting clear demargination of the borders. Then you're probably just off axis, bad angle, poor measurement, not aligned with the aortic outflow, which should be like a clean graph like you're suggesting.
Gotcha. Thank you.
This is what a pretty, if you looked at like different examples of VTI, this is pretty similar to what I think is pretty standard. But anything more fuzzy than this, I'd be worried about. And one of the big, just to your point also, one of the biggest issues is sometimes getting this extra fuzz, and sometimes people call it like the beard, and including it when it shouldn't be included because it's overgained. And so that's something to really look out for, because even if it's like a good envelope, you could still get fuzz that shouldn't be there and overestimate your VTI. So thank you for bringing.
Gotcha. So we don't include that like fuzz at the bottom.
Correct.
Gotcha. Okay.
So like, for example, on this one, like where it's clearly more opaque and then there's like that's fuzz, would not include that. If I was measuring this one here, it came all the way down, so I did measure it. But sometimes, like if there's a clear difference between the echogenicity or opacity, I should say at this point, then you would not include the fuzz. Yes. Okay. So stroke volume is, like we said, going to be pi r squared times height. So now we understand that you got, through the parasternal long axis view, we got a radius of 0.93 centimeters. Using the apical 5-chamber view and getting a VTI, we got 19.5 centimeters. So if you wanted to double check your machine, your stroke volume would be pi r squared times 19.5, which would be 53 centimeters squared. This gives you a distance in centimeters, so centimeters squared, which we know are mils. And if you multiply that by the heart rate of 70, 3.7 liters per minute. Again, you don't have to calculate this because the machine is doing it for you. Right there. Okay. So again, we use the parasternal long axis optimized for the LVOT to measure LVOT diameter. We use the apical 5-chamber view with color and pulse wave Doppler to get your VTI. Tell the machine the heart rate, you get cardiac output. And so now, fortunately, we have some time for me to just show a few common pitfalls, and then hopefully some time for questions. So what is wrong with this clip if you're measuring VTI? Sorry? Yeah, so Laura and Chris, everyone here is saying that your gated channel is in the LV, right? That channel is nowhere near your LVOT. So just, you're not going to get a good measurement, right? Your pulse wave Doppler has to be placed at the same place where the LVOT diameter was measured, right? Move that down. If you did it here, you might get something that looks like this, right? Look at where that pulse wave channel is. And so you're getting this nice, huge thing, not accurate, not accurate. See how low this is? In the LV, inaccurate. It's got to be in that channel. That's a major pitfall, very common problem. Question 2, what is wrong with this clip? We're in the LVOT. Yes?
You are, but the angle is off.
Yeah.
Well,
Exactly. Your angle is terrible, right? So off angle, off axis, you're going to get a poor measurement. It'll look something like this. This is what it comes out as, right? And again, you could do this angle correction and it'll help, but it's not ideal. You, in best case, and it would be much better if you just reoriented and tried to get it at a different angle. What's wrong with this image?
You have the valve closure within the envelope.
Yes, thank you. Exactly right. This is lined up well, pretty well. And your pulse wave Doppler is right in the LVOT diameter, but this measurement here, this is the aortic valve closing. And here I measured all the way over it and included that in the measurement. This is also, you could be worried about this, but if the patient was in shock and had really low cardiac output, then actually maybe this is a good envelope, but it's just measured incorrectly. So summary of image acquisition pitfalls, I can share this with you later. This is just reiterating all the things that we just said. I sort of made this just as a summary slide to have. Some of the interpretation pitfalls. So these are all image acquisition pitfalls. Some interpretation pitfalls, and we've covered many of them, but one that we haven't yet is that a patient with moderate to severe AR, right? So they might have a normal stroke volume, but what you're not capturing is that half of that stroke volume returns in diastole, right? So be careful in using your cardiac output in a patient with AR. We talked about arrhythmia and AFib, so that's, but just to reiterate that now, right? So if you have a patient who has AFib, then each stroke, depending on how much LV filling there has been, will have a different VTI. If you choose the biggest one, you might overestimate cardiac output. So in those cases, you should average, 3-5 VTIs. The other interpretation pitfall is what Chris was alluding to, right? Where people assume the LVOT diameter without measuring it and could lead you astray. Tread carefully. The other thing that we're going to have to talk about another time is where a patient has a dynamic LVOT obstruction, and that will affect the velocities of flow throughout the length of wherever it's moving. That's going to be a conversation for another time, but important to realize that if you do think they have a dynamic LVOT obstruction, hypertrophic cardiomyopathy, or just a hypertrophic septum with a patient with low flow, be cautious about using your cardiac output. And I will pause there for questions.
Thank you so much, Jonah. I have one more additional question. At the ultrasound conference, they mentioned also using the apical 3-chamber view and calculating VTI in that view as well. Would that, in theory, I guess that would just be an additional way to confirm and feel like you're getting a reliable number, but there shouldn't be any difference otherwise in the calculation there. Would that be correct?
Yeah, I never heard of that, but it makes a lot of sense. It's pretty hard sometimes to get an apical 3-chamber view, but I would assume that if we're calling the LVOT diameter circular, then it really shouldn't matter where we're getting which angle we're getting the flow through. So I guess if we're intellectually honest, then it should be the same. But yeah, I haven't seen it done like that, but that's interesting. Thank you.
He did both. It was cool. He kept checking over and over again to compare them.
That's great. That's awesome. So yeah.
One other quick question too. So I guess, would your suggestion be if you are trying to get your calculation and you calculate it multiple times, I think you've said before too, you shouldn't be able to overestimate this. Is that right? So the higher value in theory should be accurate.
Yeah, if it's a good envelope, right? So you could overestimate by overtracing. But yeah, but if your envelope in a patient in normal sinus rhythm, your best envelope will be at your best angle. So,
gotcha. Yeah. And then my last, sorry, I'm giving all these questions.
I'm here. I'm here till 1.
In an arrhythmia, then, like let's say you're in atrial fibrillation, is there anything you would ever be able to gather where you may try to draw the distance on through the echo for the heart rate at that VTI envelope you're calculating, or is there anything you are able to do, or it just will be inaccurate?
Yeah, no, you average. You take 5 or 6 or 7 VTIs,
okay.
3 to 5 generally. You trace because the assumption being that between those 5 beats, you've sort of gotten the average of what's happening, beat to beat.
Got it. Thank you so much.
Sure. Any other thoughts or questions? I have a question that nobody asked, which is, why don't we just measure the LVOT diameter at the apical 5-chamber and forget doing the parasternal lung axis? Shorten, yeah.
Is the angle just really hard because you wouldn't be perpendicular for like M mode to draw calipers?
Yeah, I mean, that's basically the answer. You know, this is the answer here. Some bonus content, because we have a minute that I didn't expect, which is your axial resolution. Another physics point, right? Is that just basically that your axial resolution is much greater than lateral resolution on an ultrasound. So it's able to tell the distance between two, it's able to distinguish between two objects vertically much easier than horizontally. And so if you're getting the apical 5-chamber view, you're really relying on lateral resolution. Whereas in the parietal long axis, as you remember from the previous image, I don't know if here I have it still, right? You're using axial resolution. It's also, I think, just overall much easier to optimize and getting it closer. You're much closer to it, I think, which is what Chris was saying. So you're just able to get a much more accurate measurement there. Any other thoughts or questions? I have one other point to share on this last slide here, which is not proven, but it's just my understanding of things. So you could take it the way you want, but you might notice that in this patient, like their LVOT, right, whether here and here and here, they're healthy, their valves are opening. This distance is probably just about the same, right? Because it's pretty healthy, which means that in their apical 5-chamber view, in my view, you have a little bit more wiggle room for placing your pulse wave Doppler, because if you were off by a smidge, or a smidge here, or a smidge here, or a smidge here, you're probably still at the same diameter, so you could do the same VTI. Again, I haven't seen this written anywhere, but this is just, right, this is based on everything that we understand that makes sense, right? So I think that's helpful, because when you have a patient like this is one of Saris's echoes, right? Your LVOT diameter is here, and then your aortic valve is so stenosed, right? Here, you have much less room for error, right? And I think that's just something that I keep in mind when I'm doing VTIs. Also, if I'm like not sure about exactly my angle or the distance or the depth, I can't really see the apical 5-chamber view. If I know that I have more wiggle room, I might be more likely to rely on it than if it's a patient with like AS, and if you're off by a millimeter, you're just completely off, I would hesitate much more. So I think it's just an interesting, it's just how I think about it sometimes. It would still be the leaflet tip insertions. So it would actually be here, right? But it's going to be really, really tough, because if you're off by, because you have to get your pulse wave channel there too. In theory, I mean, if you could identify this distance right here and see it both in your parietal long and your apical 5, you can go off book and say like you did it there. It should work. The math should work. It's just not the convention. So it would be very, very difficult to get an accurate cardiac output on this patient.
Do you mind if I ask one more question?
Yeah, sure, please.
Thank you. So just thinking about the flow, I guess, would you ever worry about laminar versus turbulent flow changing anything about your calculation? Or I guess in theory, even if that were a situation that was true at the leaflet insertion, that should be a point where you should have laminar flow, because it would become more turbulent as it goes through the valve. And so you can trust the velocity calculations at that insertion site. Does that question make sense, or is that just not?
Yeah, no, you're absolutely right. Yeah, if there's turbulent flow, this probably won't work either. That's one of the issues with the dynamic LVOT obstruction. The LVOT obstruction is before the LVOT, right? And then you're going to get all this turbulent flow by the time it passes there, and then it's just, I don't think it works anymore.
Gotcha.
And so one of the ideas behind doing that, you know, I don't want to scroll all the way back up, but I showed you, that identifying that beautiful blue coming sort of out of that LVOT, in addition to sort of optimizing your angle, it also gives you a sense if there was turbulent flow, because if there was turbulent flow, then usually what happens is the speeds get extremely high, and that goes above the resolution of color Doppler, and it starts just making this little sparkling appearance where it's just bright blue and red and orange, and that's how one clue of that you're dealing with turbulent flow. And if you see that also, you should be cautious and not be using Doppler for that.
Do you mind if I ask, sorry, one more question then? If you're using your color and you're trying to get a look to optimize your angle, do you ever like change the range of your color, or do you ever like play around with that, trying to like optimize the range of velocity you're seeing on your color view?
That's a great question. That is an advanced color Doppler question. Usually not for LVOT VTI, because it's standard. It's usually at around 6. So what Saris is referring to is that actually, which I said I might mention, which is here. When you have color Doppler, this shows up at your screen and it tells you that it's measuring 67 centimeters per second. And if it's going towards you, it'll be red. If it's going away from you, it'll be blue. And then if it's beyond that, then it sort of circles around in what's called aliasing, and then it sort of changes the color. That's why when you have turbulent flow and it goes to 70 or plus centimeters per second, you start getting all these different colors. And you could, depending on the physics of the machine and how deep you are, you could adjust this to have the machine optimize for different higher or lower velocities. These are sort of optimized for 67. This is generally the speeds that we're dealing with. So usually you don't need to, usually this is not what's going to clinch getting yourself like a nice clean blue outflow. The blue outflow also is not, not everyone says that that's the most important thing to do. And there are issues with color in that you could be misunderstanding what the color is showing, or if it's off angle also, it could be like you could be off axis and that's why you're not getting the right color flow. So it's just one, I think it's helpful, but it's not necessarily the be all end all for lining up your probe. But to answer your question in general, it's not that the speed is so high that you need to increase your margin here, or what's called your Nyquist limit, to identify the right flow. If you're not seeing it on these settings, 99 times out of 100 is probably because you're just off axis. Anything else, Cyrus? Or anyone else?
No, that's all. Thank you so much. I really appreciate it.
Thank you all. It's been a pleasure. I will stop the recording.
Thank you.